Thank you, Eva, and thank you to the Pain and Motion team for inviting me to speak here and hosting me in Brussels. I am a physiotherapist by training as well, and an associate professor at Auckland University of Technology here on the left, and also I have a joint position at North Shore Hospital, which is one of three major hospitals in Auckland, where I work in the Department of Anesthesiology and Perioperative Medicine. So the topic of today's talk is total knee joint replacement, which has been around or been with us since about the 1970s. It's one of the most common elective surgical procedures performed worldwide. And in fact, it was estimated that more than 3.6 million total knee joint replacements were performed in 2023 alone. And in more than 95% of cases, the indication is for end-stage knee osteoarthritis, which is also a very prevalent condition with an estimated lifetime risk for the average adult of 45%. And while it's hard to estimate how many people with knee OA will progress to total knee joint replacement, somewhere around 10 to 20% have been estimated to go on to have a total knee joint replacement. And of course, knee replacement is widely considered to have revolutionized the management of severe end-stage knee osteoarthritis, transforming the lives of millions by providing significant pain relief, reducing disability, and improving quality of life. In fact, perhaps it could be considered one of the most successful procedures in all of medicine for the pain relief that is provided for people with end-stage knee osteoarthritis. Partly due to its success, and more recently due to an aging and increasingly overweight population, the volume of knee joint replacements has increased a very large amount in the last few decades and is projected to continue to increase well into the 2050s and 2060s. The reported outcomes from knee replacement are generally very positive. So survivorship of implants is very good and continues to increase as the technology improves. Up to 92% of people report being satisfied with the outcome of their surgery. And although perhaps not the most unbiased source of information, the American Academy of Orthopedic Surgeons state on their website that more than 90% of people who have a total knee joint replacement will experience a dramatic reduction in knee pain and an improvement in their activities of daily living. So there's no doubt that overall, for the majority of patients, there is a successful outcome for total knee joint replacements. But there have been some studies that began in the early 2000s that questioned whether this was true for all patients. And it seems that there is an important minority of patients, somewhere between 1 in 6, maybe up to as many as 1 in 3, who continue to experience moderate to severe knee pain in the operated knee many months or even years after their surgery. And of course, pain is considered one of, if not the most important outcome after knee replacement for several reasons, because uncontrolled knee pain is the primary reason that patients want to undergo knee replacement, and persistent knee pain is a leading cause for patient dissatisfaction with their surgery, and also a reason, unfortunately, that surgeons might agree to undertake revision surgery, at least in New Zealand. It also has important personal and socioeconomic impacts that mean for this subgroup of people who are undergoing knee replacement, it is very important to try to understand why they continue to experience pain and what can be done to improve their care trajectory. So the million-dollar question is, for this 1 in 5 or 1 in 6 people, can we predict who these patients will be? And importantly, can we do this before surgery or in the early post-operative stage so that we can intervene early and try to prevent them developing persistent pain? And unfortunately, the short answer is no. We can't yet predict accurately individual pain outcomes, but we're getting better. And we've identified a number of factors related to the patients and to a much lesser extent the actual surgical procedure itself that may increase the risk of developing persistent pain. And when we first became interested in this problem nearly 10 years ago, we decided that the first step was to consolidate our knowledge and to understand some important gaps in the scientific literature. So our research group in Auckland performed a systematic review and meta-analysis of all the risk factors identified as important for the development of persistent pain after knee replacement. We looked for all papers that examined risk factors for pain outcomes 3 months or more after total knee replacement. And the studies had to focus only on knee replacement, not be a combination of knee and hip replacement. And they also had to have a specific measure of pain, such as the KOOS pain scale or WOMAC pain, but not a composite score. We identified 32 studies with nearly 30,000 patients who had been followed up for between 3 months and 7 years after their surgery. And where there was a specific risk factor that was examined in at least 4 patient groups, we performed a meta-regression to obtain an overall estimate of the strength of the association between the risk factor and the pain outcome. And what we found is that a number of factors, including simple demographics and surgical factors, had limited or inconsistent evidence for being a risk factor for persistent pain, and instead the key risk factors that emerged from the meta-analysis were related to the individual or the patient themselves predominantly. So all papers, So from the meta-analysis, there were 4 key factors that had consistently predicted persistent pain 3 months or more after surgery. And the number 1 was higher pain catastrophizing, measured before surgery. So this is obviously characterized by negative thoughts about pain, including the magnification of the threat value of pain. It must be something really serious. Rumination or a fixed attention on pain. I keep thinking about how much it hurts, I can't get it out of my head. And feelings of helplessness, that the pain is terrible and I think it's never going to get any better, there's nothing I can do to relieve my pain. And consistently, those patients who scored higher on questionnaires measuring pain catastrophizing before surgery were at elevated risk of developing persistent pain 3 months or more after the surgery. The second important measure was poorer mental health. And again, this was measured before surgery. So whether a scale measuring depression or anxiety specifically, or as a composite measure of mental health like the SF-36, again, if there was poorer mental health in patients at the time of surgery, this was a key risk factor consistently associated with persistent pain after surgery. The third factor we identified was the intensity of the knee pain before surgery. So specifically, patients coming into surgery with high levels of preoperative pain in their knee were more likely to have persistent pain 3 months or more after their surgery. And finally, the fourth factor identified was having other additional pain sites at the time of the surgery. So for those patients who had bilateral knee pain or had spinal pain and knee pain, or maybe shoulder pain and knee pain, they were more likely to experience persistent knee pain after their surgery, and perhaps suggesting a nociplastic pain phenotype with some sensitization of central nociceptive pathways characterized by spreading or widespread body pain that may increase the risk of poor pain outcomes. However, there were some important gaps in our knowledge. Firstly, many of the studies that we identified were retrospective in nature, so they had inherent problems associated with recall bias, and also the risk factors that they could study were limited to things that were normally captured in the medical record. Secondly, at the time that we did the systematic review, only one study in a total knee joint replacement population had used quantitative sensory testing before surgery to look for evidence of increased pain sensitivity and whether that may increase the risk of persistent pain after surgery. There have since been several more published though. And finally, despite twin studies suggesting that up to 50% of the variability in who develops chronic pain may be genetic or heritable, there had been no studies that had explored possible genetic risk factors for the development of persistent pain after knee joint replacement. So following on from the systematic review, we were strongly influenced by this paper written by Henrik Kellett in Denmark, in Copenhagen. He's sort of the godfather of enhanced recovery after surgery. And he argued that in order to understand persistent pain after surgery and to develop effective interventions, we urgently needed larger, better randomized, better designed prospective cohort studies that measured a range of known risk factors before surgery and tried to identify which of these risk factors were important predictors and how they combine to influence a patient's risk of developing persistent pain. So we decided to conduct just such a prospective cohort study of 300 patients undergoing primary total knee replacement at North Shore Hospital in Auckland, which we called the Chronic Pain After Knee Surgery, or CPAKS study. And our exclusion criteria are there before you on the slide. The study has since been published in the British Journal of Anaesthesia, so if you're interested in reading more about it, I believe it's free to access. And our main aim for this paper was to try to identify key clinical, psychological, neurophysiological, and genetic risk factors for persistent pain 6 and 12 months after surgery. And as much as clinically feasible, we attempted to standardize the surgical intervention, which included asking the anaesthetist to adopt regional anesthesia and sedation and have a defined multimodal post-operative analgesic protocol. All patients underwent computer-navigated total knee replacement with or without patella resurfacing, depending on what the surgeon thought was necessary, and all given a standard home exercise program that was supplemented by a 6-week program of supervised exercise at the hospital, which involved muscle strengthening and functional retraining and exercises to try and improve range of motion. The supervised exercise typically began about 4 to 6 weeks after the operation. That's how it works in New Zealand anyway. For all consenting participants, we scheduled an appointment 1 to 2 weeks before their operation, and we measured a number of different variables that we thought might help to predict their pain outcomes. So we asked them to fill in questionnaires related to their pain, comorbid pain sites, and also psychological factors, including pain catastrophizing, the amount of pain that they expected to have after surgery, as well as measures of anxiety and depression. We also did some bedside quantitative sensory testing, which included temporal summation to pinprick stimulation of the painful knee, and conditioned pain modulation, where the pressure pain thresholds at the knee were measured before and then after their other hand was immersed in painfully cold water. And we also measured a whole bunch of other factors, including their Leeds assessment of neuropathic signs and symptoms, some surgical factors like the duration and anesthetic type, and also their acute post-operative pain, both at rest and during movement. And the primary outcome that we were interested in was their WOMAC pain 6 and 12 months post-operatively. And if you're not familiar with the WOMAC, it's a common disease specific measure of osteoarthritis pain. We also are interested in their disability 6 and 12 months post-operatively, and we also got them to fill in the LAND score again to see what proportion of patients maybe had likely neuropathic pain after their surgery. The key stats there are for you. We used descriptive statistics to characterize their pain and neuropathic pain after surgery, and we used multivariate logistic regression models to try and identify some of the key predictors of moderate to severe persistent pain 3 months after surgery. And when we selected the best performing models, we used area under the curve and Yoden index to try and tell us about the model's ability to discriminate between people who developed moderate to severe pain and people who had no or mild pain. And we also used the Kiki information criterion to try and make sure that our model was generalizable to new patients. And what do we find? Well, thanks to some pretty heroic efforts by some of the research people involved in this, fewer than 5% of our participants were lost to follow-up, which we were very happy with. And we found that similar to international studies, about 1 in 5 patients, 21%, reported moderate to severe pain in and around the operated knee 6 months after knee replacement, and this reduced slightly to around 16% 12 months after the operation. And interestingly, more than half of the patients who reported moderate to severe pain also scored greater than 12 on the Leeds assessment of neuropathic signs and symptoms, which suggested that their pain was likely neuropathic in nature. And this was strengthened by the fact that our study was amongst the first to actually screen for neuropathic pain both before and also after the knee replacement surgery. And so we saw a substantial increase in the percentage of patients who screened positive on the LANS, from around 18 or around 6% of patients before surgery to more than 70 patients 6 and 12 months after surgery. And this graph is an example of the number of patients who reported symptoms of pricking, tingling, and pins and needles, and also brachyoldynia before surgery in the blue, and in the orange or the red after surgery, 6 months after surgery. So when we looked at what are the key risk factors that predicted moderate to severe pain 6 months after surgery, these were higher levels of preoperative knee pain on the WOMAC, higher levels of temporal summation, right, which I'll explain more about in a second, higher preoperative anxiety scores, and higher levels of expected pain, where we asked these patients preoperatively, how much pain do you currently have on a 0 to 10 scale, and then how much pain do you expect to have in your knee 6 months after your surgery? And the more pain they expected, the higher the risk of them actually having persistent pain. For temporal summation, we did this with a pinprick stimulus to the knee, and so we measured their pain score to a single pinprick onto the knee with a von Frey filament, and then we did it 10 times in a row with 1 second in between, and we asked them to rate their pain again after the 10th stimulus, and we looked at the change in pain from 1 stimulus compared to 10 in a row, and we called that temporal summation, which is again a measure of pain facilitation and thought to be a biomarker of central sensitization and nociceptive pathways. So overall, these 4 factors, if we just use these 4 factors, which are all measured preoperatively, well, the area under the curve was around 0.7, and we could correctly classify around 2 out of 3 patients. So 66% could be correctly predicted you're going to develop moderate to severe pain, you're not. Okay. And similarly, 12 months after surgery, very similar. Key predictive variables were higher preoperative pain, higher anxiety before surgery, and worse pain expectations. Right? And again, those 3 variables, the combination of them, all measured preoperatively, we could correctly classify 2 out of 3 patients and say you're going to develop persistent pain, you're not, based on those 3 variables only. So, we found a similar prevalence to other studies in the international literature, around 1 in 5 people who continue to experience persistent pain. The key risk factors we identified were all preoperative and suggested the patients who are at higher risk may have a more complex set of factors driving their pain experience before surgery. So their pain may be more nociplastic in nature, disproportionate or higher in intensity, and characterized by sensitization of nociceptive pathways, as well as more strongly influenced by cognitive and emotional factors such as anxiety and negative pain expectations. And as total knee replacement is essentially a treatment of the periphery, targeting ongoing nociception in the joints, it's perhaps not that surprising that persistent pain was more likely in those patients who before surgery their pain seemed to be more strongly influenced by central nervous system factors. However, overall, we had a fairly modest overall prediction accuracy, and as I said, both at 6 and 12 months we could only correctly predict using those factors 2 out of 3 patients. So 1 out of 3 would say you're going to develop persistent pain, and they wouldn't, or vice versa. Okay, so that's maybe not so ideal for a clinical, to use clinically. I think what was also really interesting, and we were one of the first studies to show this probably in this population, was that there was a substantial increase in the number of patients screening positive for neuropathic pain from before to after surgery. And it suggests that perhaps a substantial portion of the pain that people experience may be a new kind of pain and may be related to intraoperative nerve damage or perhaps neuroinflammation. And that is setting up the development of neuropathic pain. And although speculative, it may be that those patients whose central nervous system is more sensitized preoperatively or have more negative thoughts and emotions and stress, perhaps they're also primed to develop maladaptive neuroplasticity after a nerve injury that occurs with surgery and more likely to develop persistent neuropathic pain. And this finding is supported by recent data we've collected that's unpublished in a new group of patients approximately 9 months after total knee joint replacement, where in these bottom 3 groups that you can see here, who actually experienced persistent pain 9 months after the surgery, we asked them to identify, is this pain that you're experiencing now, is it the same pain as you had before your surgery? Is this a new pain that's developed after or since your surgery, or is this a combination of the two? Is this something that's a new pain and also a combined, like with the pain that you're familiar with from before your surgery? And as you can see, most people said this pain is actually a new pain, or that this pain is a combined pain. It's something new that's combined with my old pain as well. Of course, there's some limitations to consider. This is a single centre study in Auckland, so perhaps, I don't know how generalisable this might be to you guys in Belgium, but perhaps it is. We had some missing in-hospital acute pain data, so we could only include acute pain intensity as a predictive factor at day 7 and day 14 in our models, and that might have improved our prediction accuracy if we had been able to include that data. Of course, the LANS findings are really interesting, but we should be aware that the LANS is simply a screening tool and it doesn't replace clinical diagnosis of neuropathic pain. And although it took us a long time to collect and recruit 300 people, it's a relatively small sample size and we may be underpowered to be able to see some important risk factors. So to develop a better mechanistic understanding, towards the end of this CPAKS study, we were lucky enough to receive some additional funding to do some brain imaging on a small number of these patients. So some of the patients overlapped with the CPAKS study and some of them were new, and because we finished the CPAKS halfway through doing the brain imaging. And so these brain imaging studies wouldn't have been possible without the help of these two postdoctoral researchers here, Sheena Sharma from Northwestern University in Chicago and Karolina Wartalaska from the University of Oxford in the UK. And we had enough funding for 2 small brain imaging studies. So the first was a longitudinal study where patients underwent brain scans before their surgery, and then they underwent brain scans again 6 months after their surgery, and we compared them to a group of healthy, pain-free, matched controls. Right? And the second study was a cross-sectional study only at 6 months after surgery, where we tried to differentiate between people who developed moderate to severe pain, and we compared their brain structure to people who had no or mild pain 6 months after the surgery. So the second study was all people who had undergone total knee joint replacement at 6 months. Okay, and we used what's called voxel-based morphometry and diffusion tensor imaging, which allows us to look at differences in the grey matter density or the size of specific brain regions that might be involved in nociceptive processing and pain, and also differences in white matter, looking at the strength of connections between different brain regions. So what do we find? Well, first in the longitudinal study, we compared people with end-stage NEOA before surgery, right? So we scanned people before surgery to pain-free matched controls, and what we saw was that there were significant reductions in grey matter density in several key areas of the brain associated with pain processing and emotion, including the nucleus accumbens, the amygdala, and the primary somatosensory cortex. And we also noted a significant impairment in white matter connectivity, specifically in the midbrain, which is an area of the brainstem that's really important for descending pain modulation. And similar to previous findings after hip replacement, when we averaged the results across all patients, we showed that several of these structural differences partially reversed after surgery. And in the second study, when we directly compared differences in brain structure 6 months after surgery in people who developed moderate to severe pain versus people who had no or mild pain, the patients with moderate to severe pain had significantly higher grey matter density in some of the same regions, including the amygdala, the nucleus accumbens, and the PAG, or periaqueductal grey matter. Again, these areas are critical to emotional processing and descending pain modulation. And interestingly, when we measured temporal summation, again, 6 months after surgery, patients with higher temporal summation, reflecting a more sensitized pain system, also had higher grey matter density in the amygdala, PAG, and insula. So there was a positive correlation between the amount of temporal summation and the grey matter density in these regions, suggesting that these regions may be critical to the maintenance of pain and perhaps ongoing central sensitization of the nociceptive system after knee replacement. So of course it's important to highlight that these findings should be interpreted with caution because of the small sample size and the potential for individual variability. And inherently we're limited by the technology itself. So one voxel, which is the smallest unit that we can see when we're counting, we're looking at the size of those different regions, contains as many as 60,000 neurons, and we don't really know what those neurons do, whether some of them are inhibitory, some of them are facilitatory. But despite these limitations, I guess the findings demonstrate that before knee replacement surgery, there are clear structural differences in the brain between people with osteoarthritis and healthy pain-free controls. And these include differences in areas involved in pain processing and emotional centers, and areas involved in critical to descending pain modulation. Also, structural changes in the same or similar brain regions are associated with persistent pain and ongoing central sensitization 6 months after surgery, highlighting the potential importance of impaired pain modulation and, once again, cognitive and emotional factors such as anxiety and stress in the development of persistent pain after total knee replacement. And taken together with the main study findings, I think these findings suggest that interventions that aim to prevent persistent pain should be psychologically and behaviorally informed. Okay, I'd like to move on to a slightly different but somewhat related problem now, which is persistent opioid use after total knee joint replacement. So, as I'm sure you know, total knee replacement can be a very painful surgery to recover from. It's often more painful in the first few weeks after surgery when compared to similar surgeries like a total hip replacement. And while a mix of different pain medications are typically used to control pain, oral opioids are almost always a central component of acute pain management in total knee joint replacement patients. But in the last decade, it's increasingly been recognized that opioid use may continue far longer than the normal post-operative trajectory, and it could potentially lead to long-term opioid harms. International studies suggest that as many as 41% of people undergoing knee joint replacement continue to take opioids 12 weeks or more after their operation, but the estimates vary considerably, from 8 to 41%. Much of the data comes from large insurance data sets in North America, right, where opioid prescribing practices likely differ a lot compared to countries like New Zealand, and I suspect also Belgium. And so, to date, there was limited data available on the scale of the problem in countries outside of North America, and most studies that had explored the risk factors for persistent opioid use had looked at simple demographic factors or just whether people were taking opioids before surgery. And so we realized that we had a really interesting data set here, and that we had a great opportunity to use some of the data from our CPAKS study to conduct a secondary analysis that focused on persistent opioid use. And so specifically the aims of our study were to determine the proportion of patients who became persistent opioid users after total knee joint replacement, to examine whether persistent opioid use was associated with persistent knee pain and function 6 months after surgery, and to explore some of the risk factors that might be associated with persistent opioid use after surgery, and also daily opioid dose. And so, of course, this wasn't our main plan originally when we did the CPAKS study. So the ethics committee said we had to go back and reconsent to all 300 patients to do this study, which of course we did. We tried. And several participants of the original study had since died or moved house or changed their phone number, and we were unable to contact them. Or in a minority of cases, some people didn't want us to access their prescription medication records. Fair enough. So in the end, we were able to contact and reconsent 242 out of the original 300 patients. And the exclusion criteria there are on the slide for you again. The key differences, of course, in this exclusion criteria is that we excluded participants who didn't want us to access their medication records as well. So what we're able to do is use a New Zealand national database, prescription database, to capture all of the medications that the patients were prescribed and were actually filled. In other words, they were dispensed to them in the pharmacy. They were given to them in the pharmacy. 12 months before their operation and 12 months after their operation. And we were able to link this to their individual hospital number. And at the time of extracting this information, this database has about 95% coverage for all of the pharmacies in the whole of New Zealand. So we're pretty confident that we were capturing like most of the opioid use that was going on. All opioid medications were then extracted from the list, and we converted them into oral morphine daily equivalents using a standard conversion table, and their in-hospital opioid use was also collected separately from the medical record and converted into oral morphine daily equivalents. And to remind you, as the original study had focused on predictors of persistent pain, we had extensively characterized these patients before surgery. So we'd done QST to look at pain sensitivity. We'd done questionnaires related to psychological factors. We had blood samples to explore genotypes that may affect their mu-opioid receptor and COMT enzyme function, both of which are important in pain modulation and potentially also in dependence and addiction. And then we had a range of predictive variables that are there. So the primary outcomes this time, of course, were whether participants filled or actually received from the pharmacy one or more prescription medications, opioid medications, 6 months or more after the knee replacement, so which we very conservatively classified as persistent opioid use if they were still taking opiates 6 months after their operation. And we also looked at the oral morphine equivalent daily dose over time. The secondary outcomes were WOMAC pain and disability scores 6 months after surgery, because we wanted to see whether these outcomes were related to their persistent opioid use. And again, the key statistical procedures are there for you, and we use descriptive statistics to look at their opioid use and daily opioid doses over time. We use relative risk and repeated measures logic models to explore risk factors associated with their persistent opioid use 6 months or more after their surgery, and some more fancy multivariate models to explore predictors of daily opioid use over time. So what did we find? Well, in the 12 months before surgery, 51% of all participants were classed as opioid naive, so they didn't receive any opioids in the 12 months before their surgery. But somewhat surprisingly, 49% of the participants in our cohort had received one or more opioid prescription 12 months before their surgery. You can see that almost all participants received opioids in hospital, which you might expect. In fact, they did. And most of them received opioids from the period of discharge to 89 days post-operatively. 34% continued to take opioids 3 months or more after their operation, and this is our key outcome measure here. We found that 27% of our cohort of patients were persistent opioid users 6 months or more after their operation. The median oral morphine equivalents at each of these time points is below you here, and these were relatively low compared to international studies, particularly those in North America. So filling one or more opioid prescription in the 12 months before surgery substantially increased a person's risk of being a persistent opioid user 6 months after surgery. So 42% of people who took an opioid in the 12 months before surgery became a persistent user 6 months after surgery, compared to 13% of people who were opioid naive. So there's a relative risk factor of 3.2. And importantly, there was no relationship between persistent opioid use and pain or functional outcomes 6 months after surgery, suggesting that persistent opioid use is not driven by persistent pain. In the repeated measures models, the key risk factors for increased oral morphine equivalent daily dose over time were the average daily dose taken at the previous time point, which is called the lag, which makes sense. Patients who had a higher BMI, and also those who had 3 or more comorbid pain sites apart from the knee being operated on. And while not quite statistically significant, scoring higher than 10 out of 24 on the helplessness subscale of the pain catastrophizing scale came very close to being a risk factor. And unsurprisingly, being opioid naive before surgery was strongly predictive against against increased daily dose over time. Right? So you can see here in green, we're telling us that being opioid naive before surgery predicted lower doses of opioids at subsequent time points. And similar to previous studies, we found this relatively high prevalence of persistent opioid use after knee replacement, but in contrast to other studies in the USA, the oral morphine equivalent dose was relatively low at all time points, reflecting different prescribing practices in New Zealand, probably. And in agreement with previous literature, the key predictors of persistent opioid use and higher daily doses were any previous use of opioids in the 12 months before surgery and the average dose of opioids at the previous time point. And also in agreement with previous studies, higher BMI and widespread pain were associated with higher daily doses of opioid, which may be related to an increased risk of low-grade systemic inflammation and perhaps a more sensitized or nociplastic pain phenotype that may be less responsive to opioids. High levels of helplessness on the pain catastrophizing scale also nearly reach significance as a risk factor, suggesting that cognitive factors and beliefs may also matter too, and that perhaps a lack of pain self-efficacy and subsequent reliance on passive coping strategies like taking doses of strong pain medications may be important to consider and should be investigated in future research, as it might be an important treatment target. What we found, of course, is that the prescription of pre-operative opioids was the most important determinant of persistent post-operative opioid use, increasing the risk of becoming a persistent user by about threefold compared to people who had not taken any opioids in the 12 months prior to their surgery. And of concern, despite limited evidence that opioids are actually effective for osteoarthritis pain, and opioids generally not being recommended in osteoarthritis clinical treatment guidelines, nearly half the patients in our study had taken an opioid or had been prescribed an opioid in the 12 months prior to their surgery. And opioids are associated with increased risk of all-cause mortality in chronic non-cancer pain, and multiple studies have shown that patients who are taking opioids before joint replacement surgery are at increased risk of all sorts of negative outcomes, including increased risk of infection, increased length of stay, increased risk of readmission, increased risk of ED presentation, and increased risk of revision surgery. So, also of concern, though, was that around 13% of patients who were considered opioid naive coming into surgery, hadn't had any opioids in the 12 months prior to surgery, became persistent users 6 months after surgery, which suggests that perhaps poor post-operative opioid stewardship may also be a problem. And importantly in this study, and in keeping with previous studies in the literature and the international literature, we found no evidence that persistent opioid use was associated with worse pain or functional outcomes. And these data reinforce the increasingly accepted view that persistent pain is not the primary driver for persistent opioid use. Rather, it is preoperative opioid use and poor postoperative opioid stewardship that drives persistent opioid use. So to reduce persistent opioid use after total knee joint replacement, future intervention studies may wish to consider a number of different factors, including routine screening of patients for preoperative opioid use and openly discussing the impact of these drugs on the likelihood of a successful surgery in a sort of shared decision-making model. And where appropriate, again, under a shared decision-making model, patients may wish to undertake a controlled weaning of their opioid medications before their surgery, which is with increasing evidence that this actually improves patient outcomes after surgery. And in tandem, efforts should be made to try and improve post-operative opioid stewardship and focus more on multimodal analgesia and non-pharmacological forms of pain relief, including perhaps education and behavioural interventions to help improve pain self-efficacy in patients with total knee joint replacement. So again, there's a few limitations to consider, including the fact that it's a single centre. Of course, we could only capture the prescriptions that were actually dispensed by the pharmacy, right? That doesn't necessarily mean that the patient took all those drugs or they didn't divert them to a friend or a family member. We don't know that for sure. Some of the opioid use 6 months after surgery might have been warranted. Perhaps they fell over and broke their wrist, and so they were prescribed opioids. And so we don't know that for sure, but we tried to account for that by discarding any opioid prescriptions that had been filled less than 3 months after another hospital admission or another surgical procedure. And so we didn't include those in our final analysis. And of course, again, 242 is a relatively small sample size, so ideally we want bigger samples. So where do we go from here? How might we actually make a difference and start to improve outcomes after total knee joint replacement? Well, in our hospital in Auckland, we're in the early stages of developing a transitional pain service model of care, as first described by Joel Katz and Hans Clark and the rest of the team at Toronto General Hospital in Canada. So if you're interested in reading more about this model of care, this is the paper here in the Journal of Pain Research that you can read about what they've done in Toronto and how it's starting to be developed all around the world. The aims of a transitional pain service are to act as a bridge between an acute pain service and a chronic or persistent pain service, And specifically, the aim is to try and reduce persistent pain after surgery and reduce persistent opioid use after surgery. And to do this, all patients undergoing major surgery are routinely screened for risk factors to try to identify those that are at high risk of either persistent opioid use or persistent pain. And then these patients are offered an individualized, stratified care pathway that could include opioid tapering, it could include optimization of their pain relief or their analgesia before surgery, and enhanced monitoring of their pain trajectory after surgery, right, so that we have early referral, targeted referral into the right kinds of interventions for those patients, including perhaps early referral into a multidisciplinary chronic pain service. And throughout the patient journey, including before surgery, and very importantly in terms of prehabilitation, there is a multimodal biopsychosocial treatment that targets some of the key risk factors, including cognitive and behavioral factors, physical activity and exercise, delivered by a multidisciplinary team, including pain doctors or anaesthetists, physiotherapists, psychologists, and nurses. So related, there are some key areas of ongoing research for us related to this transitional pain service model. The first, of course, is to try and develop and evaluate the effectiveness and the cost effectiveness of novel interventions that are designed to enhance the care trajectory and try to prevent persistent pain and persistent opioid use after surgery. And the second thing that we're really interested in trying to do is to enhance preoperative screening and prediction accuracy to try to better identify and target the high-risk patients. So what do we know about preventing persistent pain? What is the current state of the evidence? Well, there have been a number of different systematic reviews published that have focused on drawing together all the available evidence for preventing persistent pain after surgery, including after total knee joint replacement specifically. And unfortunately, what these studies report is that most interventions that have been evaluated to date have been unimodal or have targeted a single risk factor with limited benefits in preventing persistent pain. And one of the only studies that I'm aware of that's taken a broader multimodal approach in a knee joint replacement population specifically is called the STAR care pathway. And that was published recently in the Lancet Rheumatology. But unfortunately, this pathway only began 3 months after surgery. So they identified people who already had persistent pain 3 months after surgery and then tried to treat it with a multimodal treatment pathway compared to usual care. And what they found is that there was a very modest treatment effect that probably wasn't clinically important. So although this is only my opinion, what I strongly believe that the evidence shows us is that we need to develop early, multimodal, psychologically informed, individualized interventions that target some of the key risk factors for persistent pain, right? And that this kind of intervention is most likely to be effective in preventing persistent pain after surgery. And so to do just that, we've joined forces with Pain Emotion here in Belgium, and we've developed multi-PrEP, which is short for multimodal biopsychosocial telerehabilitation before joint replacement. It involves one-on-one teleconferencing and instructional videos and reading material. And if you see Jonas, you can even ask him to sing you the special multi-PrEP song that he has composed. And the key components of multi-PrEP are preoperative education, including pain neuroscience education, exercise and physical activity promotion, and stress management, which are all delivered in an individualized, shared decision-making model of care using principles of motivational interviewing and solution-focused therapy. And the key outcome measures include pain and disability and physical activity, pain-related cognitive factors, and cost effectiveness. And Eva has been currently coordinating a pilot trial here in Brussels with some very promising early results. And we've just applied for funding for a full randomized control trial here in Belgium, and we're going to apply for funding to do the same in New Zealand next year. So if you want to know more about the study and you've got some questions, find Eva and talk to her in the break. The second area that we're continuing to work on in Auckland is to try and improve the preoperative screening and prediction accuracy of persistent pain and opioid use, as we believe this may eventually allow us to be more precise and to target our interventions for the patients who have the highest risk of poor outcomes, which we think is likely to enhance the overall effectiveness and also the cost effectiveness of stratified care pathways. And it may even allow us to identify patients who are at very low risk of poor outcomes who could be stratified into fast-track pathways, for example, and still have excellent outcomes. So with this in mind, we've teamed up with Professor Nick Kasabov at AUT to leverage recent advances in artificial intelligence in an attempt to see if we can improve the accuracy of our prediction models. So if you remember from earlier in my talk, using the CPAKS data, we were able to correctly predict around 2 out of 3 patients. So for 2 out of 3 patients, we could correctly classify whether they were going to develop persistent pain or not after their operation. And although still preliminary, what we did is we gave Professor Kasabov the same data set from CPAKS, and we used a bunch of different machine learning models, and the very best performing model, which is a type of deep neural network, was able to correctly predict pain outcomes for 92% of patients instead of 66%, with substantial improvements in other metrics, including sensitivity, specificity, and Yoden's index. But as with any prediction model, before we know if it's actually going to be useful in the clinic, we first need to validate this algorithm in a new sample on unseen data and make sure that it's actually still good and it's not overfitting the data. So for those of you who are not familiar with predictive modeling, the concept of overfitting can be explained simply with these graphs. Right? So the underfit model here on the left is basically too simple and it misses the main patterns in the data. In contrast, the overfit model here on the right, on the very far right, learns the training data too well and includes all the noise and all the relevant patterns that are unique to that specific data set. So when we try to test it on a new data set, it's not very good at generalizing to the new data. And the good fit in the middle strikes a good balance, captures the essential trends in the data, but also generalizes well to a new model. So our next steps are to collect data from at least 100 new patients that the model hasn't seen, and to see whether it's still as good as predicting outcomes as what the original training set that we developed. And we also want to try and see whether the prediction accuracy, if we capture these same factors earlier in the patient journey, say at the time that the decision is made to proceed with surgery, can we still have a similar prediction accuracy earlier in the patient trajectory, because that would allow us more time to intervene in terms of prehabilitation in the high-risk patients. So that's what we're doing, and we've got ethics approval for the study, and we hope to start it in the next few months. Thank you for your attention tonight. And of course, I want to highlight that all of the research I've talked about tonight is very far from a solo effort and involves an incredible team of people who deserve most of the credit. So here are some of the people, and thank you to them for their work. And finally, here's a few pictures of Auckland. And I promise you that although it's very far away, the journey is well worth it, and New Zealand is indeed paradise. So you should come and visit in the near future. Thank you.